Yeah. We'll record it. Sorry about that.
And
Here.
also, while you're on the topic of it, because it's one of the things that I've been thinking about these past couple days, when you're talking about the speed at which we've gone through everything.
Yeah.
Like me myself personally, I don't know about anybody else that I always the semester is always like the beginning of the semester, um, if you will. It always kind of starts out for me in like this haze because like man like what all are we going to cover, like what are the points of emphasis, and like how is this going to switch over to um the profession and stuff like that. I will say that, like me personally, the first two chapters, 2 and 3,
Yep.
were kind of a blur. Um, like for me personally, there are definitely some things that I've taken away from it, and that I can recall upon if I'm away from the book. But um,
Okay.
I do feel like 2 and 3 went by really fast.
Okay. Well, if you're feeling that way, probably most people are. Um,
And I think it's kind of one of those things. Like I don't want to necessarily like say that I'm lost, but like what if I'm lost and I don't know I'm lost at this point? You know what I'm saying?
yeah, I would say that every semester, whether I'm teaching this way or teaching in class, every time I've taught this class, it does seem like students initially are universally lost. Um, all right. Well, let me take that into account and see if I can um, think about doing a review, or go ahead and maybe look at my own videos and see where I might have gone a little bit too fast or didn't explain enough. But yeah, I mean, I hear what you're saying. So, but this is hard. This it's like I'm speaking a foreign language to you, and you're trying to translate. And so that's what does make this a little difficult. So, well, in any case,
Yeah, because man, I understand like we're in uncharted territory. You know what I'm saying?
yeah,
Um, but like I feel like it's not like I'm not getting anything, but I want to make sure that, you know what I'm saying, that I'm not lost, because I feel like definitely my familiarity with the layout of the abdominal region is definitely a lot better than when we started. You know what I'm saying? As far as like liver, pancreas, spleen, like even on the vascular level, like I may not be super familiar uh, with every single vessel. Um, but I mean, like I'm definitely learning, man, and like
yeah.
just a shout out to you, man, for adjusting on the fly like this. But um, at the same time, man, I want to make sure that I'm not too far behind um, before we move on.
Okay. Well, so I'm flipping through my notes here, and if you say that you have a pretty good feel of the anatomy and how everything kind of fits together, as I'm flipping through my notes, that's 85-90% of my notes is anatomy. So that's actually really good news if you're feeling comfortable with the anatomy so far. And trust me, when you start scanning, your comfort level is going to go way down. But that's normal. And so last class we talked about physiology. Why don't I think about going back over, not right now, because I want to think about how to do it, but I can go over some physiology of the liver. Um, Disease states are always difficult. Um, I can go over disease states in the peritoneum again, because that's pretty much it's been a little bit of disease state, a little bit of abnormal, and then mostly just liver function tests, and then mostly anatomy. Well, all right. We'll figure it out. I mean, I could also get some extra reading material for you. I will say that the textbook is compared to the textbooks that we were using previously. Excuse me. These are a huge improvement. Not everything. Sometimes I'll read through it and be like, "Wow, that was a very confusing statement." I wish they hadn't said it that way. But at least this book is accurate. I'll tell you, the last books, oh my God, it was like every single page there was obvious mistakes. And on this book, I really haven't seen any, except maybe like one typo. So I'm happy with the book, but it's a heavy book. Not physically, it's mentally heavy book. So, all right. All right, let's go ahead and look at these images and see if we can get something out of it. Oh, interesting. Oh no, that's okay. I just realized, by the way, guys, that I thought I could draw and then move to the next slides. This is a PowerPoint. So I can't draw and move to the next slide, so that's going to be a little unfortunate, but it just means that at the end of this, or before I go to every new slide, I have to make sure everything is off the screen. That's right. That's what Control Z is for. Okay. So let's start with left lobe of the liver. That's how most people start their scans. This is a sagittal view. This says caudate lobe. Well, yes, caudate lobe is this guy down here. He is posterior to the left lobe of the liver. There is a ligamentum venosum on this person, not particularly well seen. It dies down like that. I don't really like the term ligamentum venosum because really it's a fissure. And so what we're actually seeing is the fissure for the ligamentum venosum. And it's a very small point, it really doesn't matter. But ligamentum venosum is a landmark we look for to separate the caudate from the left lobe of the liver. Here we have the IVC. IVC is going over a circle here. That circle has to be the right renal artery. So the renal arteries tend to go underneath veins. This is a decent sized artery, actually. Most renal arteries are quite small. That's a decent size. But it goes underneath the IVC, almost has to be the right renal artery. So obviously liver, middle hepatic vein is right there. Notice no echogenic walls. In fact, you can't really see the walls at all in this. You just know that there's something here, and that's the middle hepatic vein. These circles are going in an opposite direction. Those are branches of left portal veins. Not terribly well seen here, but you could definitely see the wall, echogenic wall. Probably over on this image, you can see these are clearly echogenic structures here. But in any case, hepatic veins tend to travel in a totally different plane than portal vein. So it's not often that you see a lengthwise hepatic vein and a lengthwise portal vein in the same image. Let me see, this has got to be part of, we're only seeing, it looks like a circle, but it's not. This is actually just a cut off piece of the main portal vein. So it actually starts up here at, you can't see it in this image, but it's going to start up here at the where the two vessels meet, confluence, and then it's going to continue on more into the right lobe of the liver. So we're only catching a little bit of it right there. As we go over to the other image here, this image is a little bit to the patient's left. And what we actually see here underneath the liver, that's the very top of the stomach, if not the very bottom of the esophagus. So that's something we can look for as the esophagus or angiogram of the stomach. Of course, this is liver. These are both pretty normal appearing livers, normal echogenicity, normal texture. Back here, you can kind of see this and this are really the same thing. It's all part of that, excuse me, portal vein. This is more the confluence and sitting kind of above. Oh boy, that's hard to completely delineate. Yeah, that's part of the head of the pancreas right there above the confluence. So normal left lobe liver, caudate lobe, and sagittal. This was an interesting picture that I looked at. Really looks like some caudate lobe. Like normally you don't see a lot of caudate lobe over the aorta. This is aorta down here. So maybe not caudate, although this looks like the ligamentum venosum here, but in any case, it really doesn't matter. All that I'm saying is that from here to here, just so you know, way too much space. So this person possibly has a hiatal hernia, meaning their stomach is herniated all the way up to here. And I guarantee you, if that's the case, they have a lot of reflux as well, so a lot of pain after eating. But once again, other than that, normal appearance of left lobe liver. Transverse view, left lobe of the liver. Let's look at this picture first. All this is all gas. It's the line of gas here with dirty shadowing behind it. That is stomach. Okay. Trying to figure this out in transverse. Okay. Umbilical segment of the left portal vein. And actually, that's the ligamentum venosum right there. Very light, which means this is the caudate lobe, which means this is the IVC. So interesting. Okay, as we come over here, we see the ligamentum teres. And it shadows because it's pretty echogenic, and a lot of the sound is reflected, and so it causes some shadowing. A lot of times, this ligamentum teres is more triangular shaped, which is kind of weird. And you'll see, like, actually on a really good image, it's almost like what's that, Harry Potter? You got the triangle with the circle in the middle, the line down there. But anyway, it looks a lot like that. But this person has just a sliver of a ligamentum teres. That's completely normal. And if we could see, I didn't get a good picture of it. This ligamentum teres, actually, if we could follow it, it comes down into, or runs into this part of the umbilical segment of the left portal vein. And in utero, the blood went from here into this fissure and then dove down farther up. That's why I call this the fissure for the ligamentum venosum. But the ligamentum venosum is somewhere buried in here. So transverse and transverse view. This is left portal vein over here. We're catching a little bit here, a little bit here, and then kind of the edge over here, the edge of it over here. But that's coming across from the porta hepatis. I realize me explaining that probably doesn't help you at all because it's a rather difficult thing to understand. And that's why we look at this a lot. Okay. Oh, this was not supposed to be here. Well, okay, might as well, so I misplaced this slide. This is actually the first anomaly we're supposed to talk about, but it was supposed to be after all my normal images. The liver can be measured by the maximum dimension on a sagittal plane view through the mid-clavicular line, which is normally up to 18 centimeters in adults. Okay, so when I was doing my work, 18 centimeters is what we used, but we measured, and virtually every ultrasound tech that I know, except for this town, which is why I brought this picture up, I measured from here to here. It was kind of the maximum dimension. And this image would be generally taken somewhat through the side, through the ribs on the right side of the body. It is mid-clavicular, your clavicle being mid-clavicular would be about the same distance from center as the nipple. So we are looking at that distance. This is the maximum dimension though. And I know at least one location in town is measuring the craniocaudal dimension. Now in the craniocaudal dimension, it's 15.5, which aligns with what our book actually says. So, you know, I've done this dimension my entire career. I'll go ahead and let you guys scan that way, but we're also going to start imaging, taking measurements in this direction. So if you're doing a maximum dimension, it's 18 centimeters, which is what I did. But if it's truly a craniocaudal, it's 15.5 centimeters. So in other words, anything beyond these numbers, hepatomegaly. Unless, of course, this person has a right L's lobe. Think about that. Okay, back to some normal images again. I have no idea what GHL stands for, but this once again is the fossa, or the for the ligamentum venosum, the fissure for the ligamentum venosum. The umbilical segment, that's what US is for, umbilical segment of the left portal vein. Once again, we can't see that darn ligamentum teres, but it might be like over here, echogenic, usually somewhat triangular shape. And if you follow it down, it'll follow all the way and eventually run into the top of that. So this is a transverse view, and this is this looks awfully familiar. That's a sagittal view. We've already seen that picture. Let's try to LS left segment. In any case, this is pretty much all left lobe of liver around here and caudate lobe. Well, you got stomach. That's certainly esophagus. Oh, yeah. Yeah, that's what that is. E for esophagus is right in here. Okay, moving forward. Sagittal image of the right lobe of liver. This is a nice picture. We look at the color here versus the color here, the echogenicity of those two locations. This is close enough. Anyone who calls this fatty liver is crazy, but I've actually seen it done in teaching hospital, but they were overdoing it. This is close enough to say that this liver is not a fatty liver. And so what happens is with a fatty liver, these two echogenicities are different. What happens is the liver is more echogenic than the parenchyma of the kidney. The parenchyma is up here. Down here is collecting system. We don't have to worry about that. Further along, we have the capsule of the liver, that's the Glisson's capsule, and then beyond that is the, oh my God, Kurt, I'm having a hard day today. The thing that separates our chest from our abdomen. Diaphragm, wow. Okay, the diaphragm. And so this is the lung space up here, but we're not actually seeing lung. We're just pretty much seeing some reverberation artifact off of that. These little lines are reverberation artifacts. And then also we're seeing a little bit of a mirror artifact. So we're kind of seeing almost like a liver duplicated over here. Same thing, diaphragm, Glisson's capsule. Up here is not diaphragms over here. Up here is simply Glisson's capsule, and that's nice and smooth. That's what we want to see on a healthy liver. Both of these livers look quite healthy to me. This is also a sagittal view. We just don't have the kidney in this picture. It's a little bit medial to see the kidney here.
Real quick on the last slide that you were looking at, even though that in the picture on the left, even though that thing's right there, there's nothing to worry about.
What are we looking at?
That circular thing, like that's a normal part of the liver.
Yeah, so the only circular things I'm seeing here, this is that's a portal vein. We got just a little bit of a hepatic vein here. Looks like more portal over there. Is that what you were talking about?
No, I'm talking about that huge, almost bean-shaped thing right there.
Oh,
Yeah.
I'm sorry. No, this is that guy?
Yes.
Right kidney.
Oh,
Right.
okay.
Yeah. So this is the hard part about teaching remotely. Yeah. So when we look, this is a required image because so many people have fatty livers, and the best way to determine whether or not someone has a fatty liver, I mean, sometimes you put the transducer down and you know immediately fatty liver. Sometimes it's a little more subtle if it's only mild. And so we compare the liver parenchyma to the kidney parenchyma. This liver parenchyma is slightly more echogenic overall than the kidney, but it's not enough to call it a fatty liver. This is still a healthy liver.
Oh, okay. Appreciate you.
Yep. Yeah, no worries. It's easy to forget. I teach multiple classes, multiple students, and it's remembering where everyone's at is can be tricky. This is a transverse view of the right lobe of the liver. This is the right hepatic vein, middle hepatic vein, and kind of going off in this direction is the left hepatic vein.
Hey, Kurt, I have a question.
Mm-hmm.
So in fatty livers, can you always see the hepatic veins?
So
Like if it's a fatty liver?
with a fatty liver,
Yeah.
actually, so with really fatty livers, the hepatic veins could be very difficult to see. Couple reasons for that. With really fatty livers, attenuation is increased considerably. Also, the liver itself is becoming enlarged, and it grows. It grows in every direction it can grow, but including squeezing those veins out. So with very bad fatty liver, these guys can be very difficult to see. Okay, is that good? Tell me later. Okay, once again, so this is the same. This is the same diaphragm that we saw before. It's just a completely different angle. We looked at it before sagittal. Now we've gone transverse on this diaphragm. Once again, we have mirror artifact. So the fact that it looks identical texture to here, well, that's because it's a mirror artifact. Once again, portal vein here, going in an opposite direction of the hepatic veins and echogenic walls. So if you think about the anatomy, hepatic veins all come back to the IVC. Once again, normal appearing liver. Transverse, this would be right lobe. Right lobe liver. And we see a kidney. Not a beautiful picture, but you can see the echogenicity here and here are identical. And so this liver is healthy. We compare it to the kidneys because yeah, it probably does, but that doesn't make sense. Someone just asked a really good question. Good question, Kia. I'll go back to that. Yeah, we're going to talk more about ligaments next. Oh. All right, we have to review something. Well, we have to learn. I'm glad you mentioned that. All right. So anyway, this is transverse. This kidney, which before was shaped more like that, well, now we're looking at it transverse. So we're cutting it in half, and we're looking at it like this. It's nice C shaped. This is a gallbladder here. And overall, kind of an ugly picture. Okay, we need to go back and look at something. Yeah, so Kia asked if this is the gastrohepatic ligament. And wow, I am so glad you said something about that, because I have a small section in my notes talking a little bit about these ligaments, and I skipped it. So we're going to go back to that on Monday. But the gastrohepatic ligament, no, this can't be. I mean, that's probably what they thought. Whoever did this, I see mistakes all the time. The gastrohepatic ligament hangs off the liver and hangs onto the stomach. Let's say this is stomach here. It's kind of like it hangs like that. And in fact, there is another word for it that we have already known, and that's we've already talked about, did talk about, is the lesser omentum. I got a fly killing me here. The lesser omentum is the same deal, but all right, I'll go back and do that. Okay. Okay. So let's start talking about disease states. You will see at least a mild, and even this, I had a hard time getting a picture of a mild if this fly doesn't go away. All right, I had a hard time getting a mild image of fatty liver. I personally wouldn't even call this fatty. Now, this is too close to perfect. However, the echogenicity over here is just very slightly higher than the echogenicity there. I did work when I was a student. Actually, I was at a teaching hospital, and they were calling this fatty liver, but no one else in the world calls this fatty liver. So it's not the greatest picture to prove that. This one's a little better. Not a very good picture at all. I think it's more of a pixelated picture, but the echogenicity here is clearly greater than here. So that is, I would say, mild fatty. Whoop. Yeah, fatty. The other term, which I actually never used out in the field, but I think it is used more often in this area, El Paso area. Steatosis. Oh, in fact, don't have that written down. Steatosis. Steatosis is just another term. It's basically just referring to fat in the liver. Steatosis of the liver. Actually, let's go backwards. Just realizing you guys need to know. So this is a sagittal. These are both sagittal images. On this person, looks like their liver probably comes out down to there, which is pretty well beyond the kidney. This might be, and I don't know if I would qualify this, it's not very long, but that might be a Rydell's lobe, because it goes well beyond the kidney, but just overall looking at this kidney, it doesn't look like hepatomegaly. Some doctors are talking about changing the standard, because right now our standard is we measure the length of the liver and we say whether or not it's hepatomegaly. But like in this case, if we measure this at more than from a cranial caudal, more than 15.5, we'd have to say hepatomegaly. And just looking at this picture, I don't believe that this person has hepatomegaly. So doctors are considering taking a 3-coordinate measurement and then another one in transverse to get more of a volume of the liver. Okay, let's move on. Okay, moderate to severe. So clearly, this is a sagittal view. Here's kidney up here, the parenchyma of the kidney, the parenchyma of the liver, obviously very different. Same thing here, obviously very different. What this is showing is increased attenuation. Very high attenuation. We barely see anything in the far field of this liver. There could be a tumor down here. We wouldn't even know it. And we've had plenty of patients like that. I've had plenty of patients like that where I go to the doctor and says, "Did you see any tumors?" So I said, "Doctor," I said, I wouldn't know if there was a basketball buried in this person. There's so much attenuation in this liver." So this is an indication this liver no longer is a good window to look through. This person does appear, we have total dropout of the liver down here. So there's a lot of attenuation going on. We still see the hepatics pretty clearly. So, different people, different strokes, different folks. A lot of times when there's this much attenuation, we have a hard time seeing these. But on this person, we're seeing the hepatic veins pretty darn well. Let's scan a portal going the opposite direction. This person, obviously, huge difference between these two echogenicities. This image is too pixelated to really, I'm not going to belabor any more points on this one. I think it's too pixelated. Once again, severe stenosis in this person. They could definitely use their TGCs to fix this, but perhaps they're actually showing the doctor just how much attenuation is going on before they fix it with the TGCs. And even after the TGCs, you're still going to have poor imaging down here in the far field. I can't even tell if it's sagittal or transverse. Yes.
So when it's too bright, and that there's nothing that we can do to fix it.
So like in this picture here?
Yes.
So in this picture, what's going on is the person has their gain up. They want their gain high enough to get something back here. But they've overgained it here just to get something down here. I can't see their TGCs. For all we know, their TGC curve is totally swept as much as it can in order to fix this, and they still have this problem. So yeah, they've overgained it here in order to get something down here.
Okay.
Yeah, that's what happened there. This is fatty. I don't even know what this is. Is that a kidney? I have no idea. That's how bad it is. But this is right lobe. I could see that this is the dome of the liver, where the diaphragm is. Probably kidney. Oh, wait a minute. Let's get a little closer to my screen here. I think that's the. No, I think I over. Anyway, you get the idea. Hard to see. This person's liver is so fatty that they get this. They get this stripy appearance, and that always indicates to me that not only do we have a fatty liver, we could actually have a cirrhotic liver here. So there could be scarring inside of this liver, causing all these little miniature shadows all around. I guess that one's an edge shadow here, technically speaking, but all these other shadows have no explanation. And I see this sometimes in like an alcoholic fatty liver. So actually, let's talk about, before I get through all this and realize that I have notes. Don't want to skip that. So yes, fatty infiltration, steatosis. When it's mild, it has little effect on health. And you could take a fatty liver and turn it around to a normal liver inside of a couple of weeks. Whatever it is that was causing the fatty liver, if you change your habits or you change your medicines, there's a lot of things that cause fatty liver. You could turn yourself around in no time. Severe fatty liver does have a major effect. It could be so bad that it could actually lead to cirrhosis, which is really liver death. That's what I was looking for earlier. I couldn't remember. I knew I had something. So when we talk about all the things that could possibly do this, let's actually. Okay, so NASH, NASH stands for hepatitis. Sorry, it took me a while to type that. NASH, non-alcoholic steatohepatitis. So let's see, I guess it's really non-alcoholic steatohepatitis. This can be caused by simply being, oh, that's not going to work. Obese. Why would it put it there? Diabetes mellitus. So remember, diabetes is a sugar problem. So if you have uncontrolled sugar in your blood, it's going to go to the liver. The liver's going to make fat, and the liver's going to say, oh, look at all this extra sugar you have. We need to store this. So we're going to store it as fat. That's going to go back and contribute to obesity, but it's also the liver's running out of places to put it, so it actually puts it in its own parenchyma within the hepatocytes. Hepatitis, like a viral hepatitis, chemotherapy. I'm just going to put TPN because I'm not going to spell this one out, but because you could see this in your book. Parenteral hyperalimentation. So that is someone is unable to eat entirely and digest. So they can't just put a feeding tube down the throat. They actually have to put a feeding line, a catheter, usually through the neck into the superior jugular vein or superior vena cava, or even right into the heart itself. So that's parenteral hyperalimentation, TPN, and T stands for total. Sorry, total parenteral hyperalimentation. Metabolic disorders and glycogen storage disease, which we'll talk about those as well. But glycogen is a form of sugar, so once again, if you're keeping too much of it, that's what I was so afraid of. Okay, no. Okay, good. That was easy. Cool. Oh, I love this. Not text, draw. I love geographic fatty infiltration. So look at this line here. So for some reason, people don't always uniformly put fat in their liver. I don't think anyone really understands this, but some people get geographic. So this is fat, this is normal liver over here, fatty liver over here. And then we have a third row, so it's kind of like a Neapolitan. No, actually, that's a kidney here. But everyone likes Neapolitan ice cream. So that's one form. Here's another picture of, we have normal over here, fatty over here. So those are always pretty cool to see. You don't see this every day, but you will see it. Focal fatty infiltration. I had the hardest time getting a good image of focal fatty infiltration. because they were giving me another phenomenon. It drive me crazy. So I found this one, but this is a very, very unusual presentation. In fact, if I were looking at this, there's no way that I would think this was focal fatty infiltration, but apparently it is. So little fat, 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 but normal parenchyma in between the rest. Remember, very unusual. Because what these actually look like, they look like another thing we're going to talk about today. They look like hemangiomas. So the other weird thing, and I've seen this in some of my students just last semester, fatty sparing. And yes, by the way, guys, I guarantee you, a few of you at least will have at least a moderately fatty liver. So prepare yourselves. Prepare for the disappointment. But fatty sparing is an interesting phenomenon too. So just as you could have a focal area of fat, like like one little area of fat right there. I mean, not right there, right there. Use your imagination. Or you could have an entirely fatty liver with one little area spared. Why this happens, no one knows. It oftentimes happens in the left lobe, anterior to the portal vein, anterior, well, technically this would be right lobe because mean lobar fissure. Well, in any case, anterior to the gallbladder. So these are the two most common places to find fatty sparing. But literally, it's like the only normal liver in the parenchyma in the entire liver. Why this happens, no one really knows. By the way, this is a great view of, we have a biliary duct above the portal vein here. And this is, by the way, left portal vein, just so you know. Oh, how did that, how did you get there? Okay. Oh, the other thing I wanted to point out, look at the arrow pointing to something over here. Gallbladder. A deep, strong shadow. This person has stones. Okay. All right, nothing else on that. Okay, let's make sure fatty sparing, localized fatty infiltrate, glycogen storage, most common. Okay. So people have, and you will see this. This is not like a once in a lifetime thing. It's people do have this. Glycogen storage disease. There's a number of different disease states. The most disease states that cause glycogen, which is a sugar, storage issues. The most common, I'm spelling it how it sounds. It sounds like von Gerke, but it's actually spelled. And yes, I looked it up. Von Gerke disease. Sounds like Gerke. Von Gerke's disease is the most common glycogen storage disease out there. They have echogenic. This is a horrible picture, guys, and for some reason it was just the best I can get. But the liver is increased echogenicity, and especially with von Gerke's, they have adenomas. So we have two adenomas in this picture, hypoechoic. At least they're hypoechoic as compared to a fatty liver. We'll see what they look like in a non-fatty liver, how hypoechoic they are. Glycogen storage disease can cause some hepatomegaly and some other, let's see, adenomas, hepatomegaly, fatty liver with increased attenuation. Yeah. Okay. So hepatitis, there's all sorts of viral hepatitis is number one. Viral is number one, and that's virals hepatitis A all the way through E, technically. But we're only going to worry about A through C. And there's also not A, not L. Virals is the number one, like 95% of hepatitis is caused by a viral disease. And hepatitis just simply means inflammation of the hepatocytes, inflammation of the liver. The other things that can cause this are toxins, including a toxin also known as ETOH, also known as alcohol. So if you have too much alcohol or a lot of alcohol in one night, if you binge drink, you can create acute hepatitis. Hepatitis A is the fecal oral route that resolves in about 6 weeks. But so you get hepatitis and then it will resolve on its own in 6 weeks. You know, wash your hands and make sure people around you wash their hands. Type B. That is most likely sex and drugs. Sex, drugs, and I don't think rock and roll does it, but sex and drugs. But this too will resolve on its own. Let me erase the letter B here because I want to leave sex and drugs up. And hepatitis C, also sex and drugs. So when I say obviously sex for obvious reasons, for drugs, needles, any kind of sharing of needles. And so that also means sex, drugs, not rock and roll, but sex, drugs, and people who get transfusions it's a possibility to get it through transfusions as well. Hepatitis C, the only problem with that is 50% of those become chronic. And the only problem with chronic is that it eventually becomes cirrhotic. So we don't want cirrhosis. We don't want, in general, we definitely don't want cirrhosis. There's a term in there, fulminate. Fulminate simply means severe and sudden. Severe and sudden. So fulminate hepatitis just came on all of a sudden and it's bad. It's also life-threatening. Hepatitis can cause non-obstructive jaundice. So jaundice, well, I don't think I even said this the other day. I should have. Jaundice is an increase in, not bilirubin, bilirubin, jaundice. Yellow eyes, yellow skin. And as we learned the other day, jaundice can occur from too many red blood cells being destroyed by the spleen, like in an anemia. It can occur with obstruction. So your biliary tract is unable to remove bile, and therefore bilirubin accumulates, starts just to leak out of the hepatocytes. And then non-obstructive tends to be more with some kind of global problem with the with the liver, and so that can mess with the liver's ability to, the hepatocyte's ability to actively transport bilirubin out of the hepatocytes and into the biliary ducts so that it can be properly removed from the body. So there's a lot of things that cause the liver to become echogenic. Everything makes the liver become echogenic except acute hepatitis and maybe just a very few other things. And in this case, the liver becomes hypoechoic. Let's see, where can I? So right here is hypoechoic. Well, how do you know it's hypoechoic? Because all of these, whoops, all these things that look like they're probably something's wrong with the liver, those are actually all normal structures that we normally don't see. These are tiny little portal triads. Remember, the portal veins have echogenic walls, but we see the larger portal veins. We don't see the smaller ones. They just kind of blend in. But when you make the tissue, the parenchyma of the liver more hypoechoic, then these guys really just stand out all of a sudden. They call that the starry sky appearance. So both these livers and this liver, these all have a starry sky appearance. Once again, normal structures look abnormal in this situation. Now, that's only with acute hepatitis. With chronic hepatitis, things look a little different. Here's chronic hepatitis. Notice this is not necessarily a poor quality image. It's not beautiful, but it's not necessarily poor quality. The doctor reading this would probably call the texture coarse, like sandpaper. Like it's just what it looks like. It looks coarse, and that's a colloquial saying. It's not a technical, like hyperechoic and hypoechoic or technical terms. Coarse is just more of a descriptive term. By the way, what this person is getting, and I'll be honest with you, I've never done this. I'm a little jealous of this person, and you guys will be, by the way, out in the field. There's this is becoming really common, especially in this town, apparently. Because people are the doctors are racing each other to be the ones to say, hey, only I do this. The word was just in my head now. Elastography. Good Lord, Kurt. This is elastography. This is the region of interest right there. So they're only studying this very small portion of that liver, and what they're doing now is they're looking at the entire liver, well, portions of the liver, and figuring out how stiff it is. Remember, elastography tells can determine stiffness, and with this technology, they could really kind of predict how close this person is to going on to cirrhosis. Because the stiffer the liver, the more likely it is going into cirrhosis. A liver, by the way, if you could hold a fresh liver, it's like Jell-O, very soft texture. So, oh, I wrote it up here. I didn't have to write it out again, did I? Hyperechoic and coarse texture. 2 o'clock. Start at 1 o'clock. Yeah, let's go ahead and take a break. Let's say it's 2:05. 2:15. We'll see you guys at 2:15. Resume recording. Oh, okie dokie. All right, yeah, we stopped on cirrhosis. So cirrhosis doesn't happen overnight, but it can happen with repeated and prolonged, in other words, chronic issues with the liver or assaults on the liver. It's destruction or scarring of the hepatocytes, and it is irreversible. Once you have cirrhosis, you have cirrhosis. There's nothing else. We can try to slow it down. There's you will have some usable liver left, but what's already gone is gone. Liver is, and in fact, unfortunately, a lot of people don't know they have cirrhosis until it's really bad, because the liver is so good at you could have 10% of your liver and still feel fine. In other words, it's such a good quality organ there. Alcohol abuse can cause cirrhosis, and in fact, in Western countries, this is the number one. Really, this is the number one cause of cirrhosis. Chronic viral disease can cause cirrhosis. Chronic biliary obstruction can cause cirrhosis. Hemochromatosis is a problem where the liver stores, through just malfunction or too much iron. Wilson's disease, it stores too much copper. Galactosemia, I had to look this one up. I've never even heard of it before, but it's someone who cannot process, does not have the enzymes to process galactose, a form of sugar. So when people get cirrhosis, there's initially hepatomegaly. Another term for that really is hypertrophy, but hepatomegaly is number one. And then after a while, atrophy. The caudate lobe, which is oftentimes spared the disease, can become hypertrophic. In other words, the rest of the liver isn't doing its job anymore, so the caudate lobe will actually grow larger and do more of the work itself. There's nodularity. Now, this is a pretty ugly, but one of the things we notice on the anterior wall, especially nicely seen with this ascites here, is a nodular surface. This is a really telltale sign. Over here, this is nodular as well. The liver should never look like that. And sometimes this could be very subtle, but we could clearly see it with ascites. So of course, ascites forms, excuse me, in the presence of cirrhosis, probably because of the liver is no longer creating enough albumin. So remember, albumin creates our my God, Kurt, it's definitely Friday. Our osmotic balance is through albumin. And if you don't have enough albumin, water, fluid, blood serum starts to leak out of the tissues and into the peritoneal cavity. And also, obviously, you can see very heterogeneous view and all these little nodules inside the liver as well. And this liver will never be the same. Cannot go back. Regeneration is the liver does actually attempt to go back. I don't see, a lot of times these nodules are actually attempts at regeneration. Actually should have put that in these together in one. But the problem is that even though it's trying to regenerate, the nodules themselves, if you could look at this under a microscope, completely disorganized. The hepatocytes are disorganized. The portal veins, the hepatic arteries, the biliary ducts are not lined up in the way they should be, like we saw the other day in a nice honeycomb appearance where with the intact portal triad. That completely is, when these try to grow back, it does not happen. So it could do all it can to try to grow back, but it's not going to work, unfortunately. Well, that was interesting. Caudate lobe hypertrophy. This is a transverse view. Remember, when we saw the caudate lobe earlier today, it was kind of like that big, right? Now, this is the caudate lobe. So it's increased considerably, although same echogenicity across from caudate lobe over to here. So I don't really know how bad this person's disease is, but it's definitely an enlarged caudate, which is interesting. Notice also the caudate is having it's called a mass effect. So it's almost like, wow, is that really even the caudate lobe? Because a mass effect will take and push things around. Like it's literally like a mass effect means it's pushing. In this case, it's taking a, looks like the left hepatic vein, and it's pushing it off to the side here. So it's having a mass effect. That's the aorta down here. So you get an idea of how big this caudate lobe is. And over here, ligamentum venosum. There. Caudate lobe is below the ligamentum venosum. So that is a huge caudate lobe on this person. And if you look very carefully, nodularity up here, not quite smooth. The cirrhosis has very different appearances on different people. Nodularity over here as well. So on the last, let me go back to the last image. Yeah, you know, anyone who spend one day scanning normal livers can see that this was an abnormal liver. This one maybe not. You might not notice that on your, you know, if you're new. But the parenchyma here, you know, that parenchyma looks decent. But why else would we have such a large lobe here? And same thing over here. The parenchyma looks more or less normal, but there is some nodularity and a little nodularity on the bottom side as well. Okay. Let's see, what else do I want to say? Make sure I don't. So initially hepatomegaly, everything gets big. Then as it starts to die more and more, and it gets small. And then the caudate lobe will get enlarged in order to take over the job of the liver. Surface nodularity, coarse texture. Well, portal hypertension. So I was going to skip portal hypertension. Suffice it to say, I'll give you this much. Portal vein comes in. I'll just draw a pretend portal vein right here and distributes blood to the liver parenchyma. Well, the portal vein, it is a vein after all. It actually has fairly high pressure, which is why you never see a portal vein flattened out. It has fairly high pressure, unlike most veins. So it stays open, and it's pushing a lot of blood into this liver. But if this liver doesn't want to receive it, the pressure in the vein is going to increase even more. And that has a wide range of consequences that we will talk about maybe on Monday. Definitely soon, if not on Monday. All right. Oh, here's another great picture. I love this picture because here we have left lobe of the liver. Let's start with the less obvious part. Yeah, I mean, it's a little coarse. I don't know if that's something or not. It could just be an artifact, but it looks like something there. Maybe a little nodularity there. I'm not so sure I'm seeing nodularity. It's a little on the coarse side, but definitely increased echogenicity. So even without comparing it to the right kidney, it seems like it's fatty. But look at this caudate lobe down here. So that caudate lobe is large, which tells me, one, it's becoming hypertrophic. It's growing larger because the body needs it. But it's also spared. So caudate sparing of this fatty tissue up here. So it's kind of a twofer on that one. But that was an interesting picture. Yeah, so the biggest thing we'll go back and talk about would be the portal hypertension. That's the, other than the fact that the liver is just simply not working, that's probably the number one thing that we're going to look for as sonographers is portal hypertension. Once we've already described the liver, which only takes a few minutes of our time. So liver cysts, simple cysts. We're not talking about anything complex here. So anechoic should be pretty much 0 echoes inside of here. This person has through transmission, but very weak through transmission. I don't know why. Don't know why. Through transmission over here is quite obvious. Oops, can't draw straight. In any case, this area right here is nice through transmission, and it's going off sideways because, well, that's the way our beam is coming down. This is not a cyst. That is the IVC. Notice the IVC, aorta goes completely and utterly underneath the liver, does not go through the liver at all. IVC does actually go through the liver. So this person has, as far as we can tell, 1, 2, 3 cysts on that liver. Only this one has obvious through transmission. That could be settings. Could be that they're using an ATL, which is ancient technology too. Liver cysts, congenital, incidental, developmental, meaning they develop over time. So when you're 5 years old, you don't have any cysts. When you're 50, you do. It's developmental. They need to be thin-walled. Anechoic, I mentioned. Acoustic enhancement. Refraction shadowing is also seen. I'll be honest with you guys. If I only saw this picture right here, that so-called cyst right there, I'm not 100% sure I'd call it a cyst. My brain would want to call it a cyst, but you got to see more information because sometimes a solid can be very anechoic without through transmission, although even a solid would still have edge shadowing. Anyway.
On that image right there on the right, how come there's so much posterior enhancement at that one at the bottom, the one that's the IVC? Because
yeah.
I'm guessing that's the diaphragm that's moving right there.
Yeah.
But then it also has, like, is that like an artifact or something going on right there?
I think so, because the funny thing is about blood vessels, fluid has posterior transmission. Blood vessels oftentimes don't, and you'll see that in the liver. Like sometimes a simple. Let's see. I have to do a. Oh, I'm going to regret that. Actually, yeah. I mean, whoops. Really, no through transmission behind the IVC. Nothing behind this portal vein. Nothing behind this hepatic vein up here. And that's an interesting thing because sometimes, you see this little circle here, and if you circle there, and you think, how would you ever find a cyst that big? You really will, because cysts, if they're filled with just a simple fluid, will show through transmission. And what you'll actually see is, and I could flip through a liver real fast and suddenly see a cyst this large. And I first started, I couldn't, because it looked like everything else. It looked like all these other hypoechoic structures. But yeah, blood vessels usually don't. And I'll be honest with you, I don't completely understand why, whether it's the content of the blood, the walls or whatever. But Yeah, but in any case, to answer your question, this is mostly um, the diaphragm. And then perhaps it's a little thicker here because the diaphragm has to enlarge and fold over itself in order to allow an IVC to go through it. But that's a guess on my part.
Okay.
Polycystic liver disease, PLD, this one is rare. Isolated polycystic liver disease is rare. Here we have, oh, this is left lobe of liver. The reason I know that because here's the aorta down here. So this has got to be all left lobe like that. And that's a transverse view, obviously, since we're looking at the aorta and transverse. And these are all just cysts. Cysts upon cysts, wrapped in cysts. Another image, God only knows where we are in the liver on this one. But obviously these guys can become pretty significant. With polycystic liver disease, it's a different, because there's also polycystic kidney disease. They have a very similar appearance, but they are different in how they're created. This polycystic liver disease, these are basically bile ducts that have been clogged up, and if they can't drain, they become cystic. The images that I found for polycystic kidney disease on ultrasound all looked identical to this. And so with polycystic kidney disease, it's rarely only the kidney. It's the kidney and the liver, and sometimes some other organs as well, but mainly kidney and liver. And it looks just like this. The kidneys look like this, the liver looks like this. So I didn't get any more ultrasound images. I instead got CT images. Polycystic kidneys themselves can be dramatic. Here's the right kidney. Normally and this is a transverse view, so normally its transverse size would be about like that big. So these become enormous. They're the longest one I measured. I marked on the skin where the top was, then I marked on the skin where the bottom was, and I took out a tape measure and measured on this person. And this man looked like he was pregnant, and it was just two gigantic kidneys. But in any case, this person, this is liver up here. And by the way, we have there's a portal vein here. Oh, look at that. Oh, I gotta, okay. Okay, that's part of the liver, obviously not the whole thing. We got a portal vein coming in here. And then, these little cysts here. So this person's liver cysts aren't too bad. This person over here, and obviously here's the other kidney. This person over here, a coronal view. Here are the kidneys. Oh, probably up to there. Spleen is spared any kind of cysts, but the liver, look at see how the right hemidiaphragm is higher. This is all, I don't even know where it ends, honestly, but this person's liver issues are considerably worse. So this person not only has eventually non-functional kidneys, eventually this liver will be non-functional as well. Hopefully this person's liver will continue to function normally. I just want to show you guys something. This is so cool. That little circle right there, that's the ligamentum teres. And it's sitting inside of that triangle of tissue, the falciform ligament. Ah, that is awesome. Did I mention I have some CT images at the end because you guys need to learn how to read a CT. I became quite good at it because when you stare at a CT prior to seeing the patient, you know where to put your transducer in order to find what you're looking for. Because a lot of times we're following up CT. Sometimes CT follows up our work. But if there's previous studies, then you definitely want to look at it. So autosomal dominant polycystic kidney disease. This is adult, also adult onset. There is a child onset or fetal onset polycystic kidneys. Autosomal dominant tends to be the adult kind. And you will see those. It's not every day, but you will see these kidneys and associated liver. Yeah. Hematomas, in this case, subcapsular. In other words, under the capsule, Glisson's capsule of the liver. So we have a couple, yeah, these are two different people. This almost at first glance could look like ascites, but it's only right here. This person has bleeding of the liver and it's going underneath the capsule, Glisson's capsule, so it's maintaining, it's having a mass effect, it's pushing the liver away in that direction. Same thing, and this is a sagittal view of the liver here. So the liver should be all the way up to here. Another one. This is a transverse view because we're seeing kind of dome more like that rather than over here, which is sagittal like that. And once again, blood going underneath the capsule of the liver. This very well could have been trauma. It could have been a needle stick. This next one, this was trauma. I know this is a horrible picture, but the liver and the spleen more so than the liver, but both of them can fracture or crack like an egg with hard enough. This person had a car accident, MVA, motor vehicle accident. Liver fracture with contrast. So there's contrast. That's why this is so echogenic around the edges here. That's actually contrast enhancement. But the contrast does not cross over this somewhat linear hematoma. So this is a fracture. It could also be a laceration. 6 of one, half dozen of the other on that. It's just a tremendous accident, and this person's liver just ripped open. So resolving or organizing hematoma with a fluid level. So sometimes when you see, doesn't have to be a hematoma, sometimes we see cysts with one kind of fluid here, one kind of fluid here. It's like a lava lamp. And that's called a fluid level. Evolution of a hematoma. And this comes up a lot, the evolution of a hematoma. I wrote more down for that, but surprisingly, even though blood is anechoic, when a hematoma first appears, it could be echogenic, and that's because of fibrin, and stagnant red blood cells. When red blood cells are speeding through the blood, they're separated, they're far apart. You really don't see them. But when they're stagnant, when they're all just sitting there and accumulating, they gather up, and suddenly that fluid becomes more echogenic. And when you include the fibrin, which is basically clotting material, very quickly, unless the blood is literally bleeding as you're looking at it, then it's anechoic, but very quickly it becomes echogenic. Then it becomes complex as it's sitting there, and the fibrin really makes a strong blood clot. It could be it's complex, cystic solid, and then it becomes anechoic over time. So this part of the hematoma here is probably more of a seroma, leftover blood serum. And then this is leftover, this is resolving, this is blood clot, old red blood cells, all sorts of stuff that the body is eventually going to absorb and get rid of. Ah, yes. And even though I raised sheep, I was lucky never to get this. Hydatid cyst. You know, there's another term for hydatid cyst. Oh, well, yeah, right there. Oops, that's actually Conococcus, which is a type of tapeworm. And the primary intermediate host, yeah, the primary intermediate host is sheep. There's a few other animals, but sheep is the number one. So we would normally see this in New Zealand, somewhat the American West, although we've seemed to have done a pretty good job of eradicating this, or at least not eating raw sheep, I guess, or mutton. Certain parts of the world would see this, but it's not unheard of in the United States. It is a tapeworm that, while you ingest, and the larva stage of the tapeworm, well, you ingest. What happens? It goes through the GI tract, and it goes through the intestinal wall. Once it's in the bloodstream, where does it go? Straight to the liver, because that's what our portal system does. It brings everything from the intestines to the liver, including some things we probably don't want to see. And so the Echinococcus, these are all the same species. They do have some different appearances. The honeycomb appearance, the water lily appearance, and this is just, and we'll just simply call this the daughter cyst or complex appearance. Each one of these is considered a daughter. Daughter cyst. This one, this is the water lily. Water lily. All right, water lily. This is not a daughter cyst. Oh gosh, from my memory, I'm sorry, I'm doing this from memory, but these cysts will die over time, and the epithelial layer of this will slough off. And so what you're seeing here used to be where this blue line is, you know, the outside of the cyst itself, and so it's sloughing off. The most common sheep herding areas, inject larva, portal liver. Yes. Fortunately for my patients, unfortunately for me, I have never seen one of these. But it would be pretty awesome if we did. Abscesses, pyogenic abscess. Pyo is pus forming. I'll tell you, When I was a student, my instructor was a very loud man. He was from another country, and he had a very extremely loud voice, and he was talking about the abscess. He says, the pyogenic abscess, it is filled with pus. It is pussy, and everyone's writing down notes, and everyone stops writing. I look down, everyone stops writing, and I raised my hand. I said, how do you spell pussy? And yeah, that is how it's spelled. So it's not my fault. That's just the fact of life. So pyogenic is pus forming. Pyogenic, pyo is pus, genic is to form. And abscess, abscess meaning yuck. Pyogenic abscesses. Oh, number one reason. Well, immunocompromised people usually, but it is from mostly E. coli. In other words, your own probably came from if you have a pyogenic abscess in your liver, it probably came from your own intestinal tract. This happens all the time. E. coli is always going through the intestinal tract into the portal system, into our liver. But we have, remember, Kupffer cells. Those are those phagocytotic cells that find E. coli and eat them. But if you have a depressed, compromised immune system, you might not have Kupffer cells that can handle that, and so E. coli can get into your liver and spread. So typically round masses, typically hypoechoic and heterogeneous. In other words, dark, but somewhat, like this is quite heterogeneous, this one. Irregular walls, like this one's pretty irregular, though I could say where the walls are. I could measure this. It's actually really hard to put exactly where do I put my calipers when I want to measure this particular one, or these number of abscesses here. Notice that there's actually one forming right here with a central, we call that a central scar. You guys see that? It looks like a separate abscess here, a separate abscess here, a separate abscess here. Yeah, maybe there. Indistinct walls through transmission oftentimes, and yes, we can see through transmission. Here it's not very obvious, but it is there. That's because this is mostly fluid filled. Yeah, I would say through transmission there as well. Once again, not obvious, but it's there. So pyogenic abscesses. Let's see, next one, amoebic abscess. Amoebic abscesses and pyogenic abscesses, oftentimes, you're not going to know the difference. You're simply not going to know the difference, but this is a little scary looking, actually, because cancer sometimes has really, oh, it looks like a bear. Cancer oftentimes looks like a bear. No, cancer often has very irregular walls because it's growing outward. But there would be no blood flow inside of this. So if you put Doppler on, you would not see blood flow at all. Amoebic abscesses or ambidiasis, don't drink the water. So if you have amoebas in the water, you get Montezuma's revenge. And if you're unlucky, you get Montezuma's revenge and a abscess. Oh, looks like an abscess or two in the liver. Like I said, you're not going to know the difference between these abscesses unless you have some other evidence. They just came back from Cancun, and they were out drinking the water on the surrounding villages, and they had ambidiasis in the water there. It happens. Schisto, holy schistosomiasis, schistosomiasis, sorry. That is a parasitic worm. I forgot exactly where these are endemic, but we will see them. It's a parasitic worm. Once again, you ingest it. It goes through your intestinal wall into your portal system and up into the portal veins. But then once it gets to the portal veins, it stops. It grabs a hold of the wall and crawls inside of it. And once inside, it makes the portal triads. They're echogenic already, but now it makes them larger and even more echogenic. This is actually pretty dramatic here. So when you see an otherwise normal individual, but maybe perhaps someone who came in from another part of the world, and they're complaining of abdominal pain, LFTs are increased, and you see these portal triads that are just unbelievably large. And then over here, once again, kind of a little tortoise shell kind of a shape to them. You can suggest to the doctor schistosomiasis. That's another one I've never seen, so you're not going to see these every day. HIV/AIDS, people with compromised immune systems, especially AIDS patients, can get pneumocystis pneumonia, which is actually a common human fungus found in the lung, or the cause from a common human fungus. Giravicelli, I don't even know how to pronounce it. Sorry, I didn't look that one up. But this is a common fungus in human lungs. We all probably have it in our lungs, but if you are immunocompromised, it spreads, and it will show. Innumerable. It's a nice word. Innumerable. In other words, if it was innumerable, you'd be able to count it. Innumerable, you can't count them. Innumerable bright echoes without shadowing. None of these bright echoes have shadowing, because if there were calcifications, at least some of them would shadow. The larger ones would. But innumerable echogenicities, and look at here, kidney as well. Kidney has them as well. So yeah, that's pretty much all I've got to say about pneumocystis pneumonia in AIDS patients. Oh, 256. Awesome. Awesome. This is going to work out really well. Perfect timing. Fungal infections. Once again, Candida albicans. I don't know, white Canadians. It's a normal part of our flora, found in GI tract, mouth, and vagina. But in immunocompromised persons, this can spread throughout the body. Wheal within wheal within wheal is a descriptive term. Some of these descriptive terms are used by doctors, so it's worth knowing. There's that wheal, there's another wheal. Sometimes called a target sign. I don't know why on this particular one they call it wheal within the wheal rather than the target sign. But this is a close-up view of one of them. And this is actually a child who compromised immune system, had really bad infection here with Candida albicans, the white Canadians. Damn white Canadians. All right. And if I'm going too fast, Slow me down. Cavernous hemangiomas, these are common. You will find these. I wouldn't doubt that we find them in one of you this semester if we ever go back. This is the typical appearance is echogenic, round-ish, small-ish. You know, maybe that small, maybe that, you know, something like that. So they're not typically very large. This one's really echogenic. This is almost atypical. It's so bright, but I do believe it is still a cavernous hemangioma. What can I say about these? So most of the time they're echogenic. Most of the time they're homogeneous. This is fairly homogeneous, I guess. This one's certainly homogeneous. The same. It's like the same texture of the liver, just more echogenic. Last semester, started scanning on the first day of abdomen, and I was showing someone how to scan the left lobe of the liver, and one of my students had atypical. Well, she had lesions. She had tumors all over her left lobe of the liver, and it was scary. They were not good-looking tumors. And I pulled her aside and said, "You get yourself to a doctor." And she did, in fact, have her liver scanned with CT and with contrast CT, and they were able to determine that they were, in fact, hemangiomas. So hemangiomas, so the contrast in CT means that they're able to see the blood flow into the tumor. Typically, we don't see a whole lot of blood flow inside of hemangiomas because the flow is really slow. But I was actually able to get the blood flow in there in hers. And but in any case, let me show you a little more atypical. So here's an atypical hemangioma that is hypoechoic. One would not look at this and say, "Hey, doc, I found a hemangioma." You might keep that in the back of your mind that it could be a hemangioma, but you would definitely not say, "Oh, doctor, don't worry about it," or say to the patient, "Oh, dear God, no." You'd never say to the patient, "Oh, don't worry, it's just a hemangioma." But this is actually a hemangioma. This guy, you know, is a hemangioma, which is kind of interesting. It has a halo of hypoechoic and then more isoechoic in the middle here. But that's supposedly, according to whoever wrote it, was an atypical hemangioma. This one is very large, so could qualify as a giant hemangioma. And this one also has a central scar. These scars are significant to doctors. This is something that's worth mentioning. So my students always ask, what do I say? I say, well, echogenic structure with irregular walls, largest dimension, 4.5 centimeters. I remember about 4.5 by 4.5 by 4 by 3.8 centimeters. I'm just making things up, obviously. With a central scar, echogenic structure with a central scar. And then you do the doctors a favor when you remind them, like, "Oh yeah, I got to mention this echogenic scar." But in this case, what probably just happened is that it's a little necrosis. In other words, it's dead, died in the middle here because maybe perhaps a lack of flow or whatever. But that's a probably central necrosis in that. Focal nodular hyperplasia. I love showing students this one. Focal nodular hyperplasia is, you know, so far we've been talking about benign stuff. This is benign. It has all the elements of normal liver tissue. It has hepatocytes, Kupffer cells, bile duct elements, biliary duct elements, but they're just a little disorganized. And because of that, they're probably somewhat non-functional part of the liver. But on this one, this is it. Isoechoic could be very difficult to see. If you're speeding through an exam, you will not see that. But I think once I've pointed out, not to mention the arrow pointing to it, I think you'll be able to see that that is what that is there. This one, and kudos to anyone who sees this. It's right there. I'm going to take that away. Control. I forgot what the other one was. All right, well, anyway. So focal nodular hyperplasia. Sometimes they're a lot easier to see than this. They might be a little bit hypoechoic, but this one is certainly isoechoic and very difficult to notice. Yeah. Now, adenomas are kind of similar. They are overgrowth of hepatocytes. The difference with these is that they have only hepatocytes. Excuse me. There's no Kupffer cells and no real bile ducts. So it's these are certainly non-functional structures. And I think your book, was it your book? Yeah, your book mentions something about one way to tell the difference is for the Kupffer cells and the uptake. Well, what they're talking about there in the book is a well, it'll come to me in a second. You put radioactive tracer material into the body. And what you're able to do is find something that Kupffer cells will take. They'll take up when it finds it. And so when you put that radioactive tracer in, if whatever you're looking at draws up a lot of that trace, then you say, focal nodular hyperplasia. If the tumor that you're looking at does not take up any of that because there's no Kupffer cells in there, then you say, okay, now I'm leaning towards an adenoma. Nuclear med. I'm so glad it's Friday. Okay, let's get through the last of these. Adenomas. I'm sorry, let's make sure I say everything. Adenomas. Von Gehrig's disease. Those people. Those people. Glycogen storage is Von Gehrig's is a type of glycogen storage disease. They are very common. Have adenomas along with them. Of course, the adenomas we saw earlier in this were very hypoechoic, but then again, the liver was so echogenic, which helped make them look hypoechoic. Oral contraceptives and anabolic steroids. So mess with your hormones and you'll get an adenoma. Lipoma. Well, what's the difference between, now this is very echogenic, and it's actually a pretty horrible image, and this one's very echogenic too. But we could say, well, gosh, I think that's just a hemangioma, because we see hemangiomas all the time. We don't see lipomas very often. But there's a cool reason, guys, why this is a lipoma. We learned it last semester. See, a hemangioma really doesn't mess with the speed of sound, whereas a lipoma, speed of sound slows down, right? So you get a speed artifact. So here's our here's what should be our diaphragm should just continue to move on like that, or the Glisten's capsule, or both, whatever. But instead, there's a defect. And look what's above the defect. That strongly suggests that this is a lipoma. Because and same thing over here. Just stops, starts again. It's kind of I can't really explain why it's flat like that, to be honest with you, but it is a speed artifact over here as well. So I love that. I love that I found that picture. Okay. End of, well, today's, and the next time we talk about this chapter, we'll be talking about cancers. But know your CT images. This is really important, guys. So I'm gonna work with you really quickly on this. Transverse image, just like right, left, anterior, posterior. So posterior, of course, we see spine. But look what's, oh God, there's so many cool things in this. I should have been a CT tech. No, I'm not kidding. You just take pictures. Right kidney, left kidney. Liver. Oh, just a little bit of the spleen. Seen over here. Not the whole spleen, not the whole liver for that matter, but just a little bit of it. Gallbladder. Awesome. Pancreas. If we could see more of the pancreas and more of the spleen, we would actually find the tail going right into the splenic hilum there. I want you to notice something about the pancreas, and we'll talk about the pancreas soon enough. Look how it's just kind of, it's almost fuzzy. The pancreas doesn't have a Glissen's capsule or a renal capsule. There's no pancreatic capsule. And so on CT, you can clearly see, well, you can clearly see that you can't clearly see a capsule around it. There's a good reason for that, but I'll talk about that later. Look at this. Aorta. Awesomeness. Guess what this is? Oh, loving it. Loving it. Anyone? Crust of the diaphragm hanging over the aorta right here. And so this continues to be some diaphragm down here. Loving it, loving it, loving it. At this level, the IVC is parallel to the aorta. If we go a little higher up in the abdomen, just a little bit, the IVC will lift up and go through the liver. Love this picture. Oh, of course, what hangs out over the aorta? What circular structure? In transverse, nothing but
SMA.
Yes! Good job. So there's another vessel, Smarte Pans. Posterior to the pancreas. I'll finish drawing it.
The splenic artery.
Splenic vein, actually. It's all right though. Some intestines. By the way, air on ultrasound is bright white on our screen. Air on CT is black. So that's intestines over here with some little air, also known as UVFs, but that's for another day. Let's see. Oh, okay, this is part of the liver too. Couldn't figure that out. I was like, what the hell is this? That's part of the left lobe of the liver, right lobe of the liver. Obviously, they're not totally separate. They're connected, just not in this particular plane. Awesome. Another picture. Oh God, this is so stinking cool. Look at the separation here between I almost said that wrong. Left lateral and left medial lobes. This is gallbladder, so let's see. This is right. So at this particular level, and look at this, technically speaking, everything's on the right side of the body. So that tells you that the left lobe of the liver doesn't necessarily mean the left side of the body. It is much of the left lobe is over on the right side of the body. Love this, but basically we're seeing just that little line right here, ligamentum teres, sitting inside of basically the falciform ligament, which is going to come across here. Dang it! Oh, I'm loving this, loving this. This pancreas, once again, look at how there's no capsule around it. It's really kind of really fuzzy looking, coming all the way down to the hilum of the spleen. Oh, confluence, or maybe not even confluence. Maybe that's, okay, it's not confluence. It's almost the confluence. So you have a one vein coming up this direction, the splenic vein, another direction coming in from our point of view straight down, superior mesenteric vein. Maybe the confluence. It's hard to know for sure, but superior mesenteric vein, SMA, aorta, IVC, and look at that going between the two. Let's go all the way back to this kidney. Renal vein, the left renal vein, over the aorta, under the SMA. Okay, it is a holiday, so let's keep going. So yeah, we don't have to. Well, that's a cool progression, but let's do the next one. Oh, this one's awesome. I can't even, don't look at this over here yet. Portal vein coming in and spreading out, right? Oh, this person's got a really long, almost a Rydell's lobe. I don't know if I'm going to call that Rydell's lobe or not. But that's a really long right lobe of the liver. Gallbladder here. Stomach. Oh, just a little bit of spleen. Now, this is exciting. What the hell? Why is this person's? Huh? It was exciting until I couldn't explain it. Superior mesenteric artery. Supposed to be feeding this side. Well, we're at a certain level that we can't see. There's a lot more of this mesentery, but superior mesenteric, maybe that's inferior mesenteric. How far down are we? Oh, yeah. I'm sorry, that is inferior mesenteric because superior mesenteric would come off more at this level. So inferior mesenteric artery feeding, all right, a little bit off to that side, but for the most part, feeding the right. This, you could actually see the mesentery holding the intestines together. Vessels are trapped, these vessels are inside of this mesentery, this peritoneal folds of creating the mesentery. So that is the inferior mesenteric artery. Scared myself there for a second. The superior mesenteric artery is not seen because you're probably just a couple of centimeters too deep into the body. Oh, hepatic flexure. So colon's coming up, comes across. So when you say the hepatic flexure comes up to the liver, that's what they're talking about. urinary bladder down here, small bowel, second colon, pancreas. Yeah, a little, I guess a little bit of pancreas there. Cool. And then one last picture, just for the heck of it. So if this picture is let's say halfway through the body, this next picture is all the way down by the back. And so you're below the intestines. You're actually in the retroperitoneum. So left kidney over here, right kidney, a little bit of spleen, liver, tumor, some kind of tumor in this person's liver, which is interesting. Psoas muscle attaching to the spine, eventually goes down, can't see it all the way, but eventually goes down and attaches to the femur. Oh, I wonder if we could see layers of no, the muscle layers. We can't quite see it. I guess that's all for this person. All right, cool. Let's see, almost 3:20. Great job, guys. We went through a lot of stuff today. You know, if you guys feel like you've missed anything in particular, or feel like geez, I don't get something, you can email me, you can call me, text me. Just don't keep it to yourself, because if you do, then not only will you not learn, but other people who probably have the same question won't learn. So let me know. Have a great weekend.
You too. Thank you.
All right, take care, y'all. Happy Easter. We'll see you on Monday.
Bye.
Bye.